Welcome to Department of Pediatrics at Leaf National Medical University. My name is Ri Gerasimov. I act as Associate Professor of Pediatrics at the mentioned department. Today we will speak about the blood pathology in all the children. Generally speaking, blood consists of erythrocyte, leukocyte, thrombocytes, and coagulation proteins, resulting, in the case of the pathology, resulting in different disorders. So we will speak about today. So, and we start with the pathology of red blood cells, calling anemia. Anemia from the Greek means that absence of life, and indeed, patients who lack erythrocytes, mm, they feel constant weakness. So, by the definition, anemia is defined as a reduction of the red blood cells volume or hemoglobin concentration. And by the definition, so we suppose the patient is having anemia in the case in the children under 5 years. So concentration of hemoglobin must be 110 and less gram per liter, and above 5 years must be more than 120. And hematocrit, normal hematocrit, it's 45 to 55%, so as to compare it with plasma. What are the pathways resulting in anemia? It is suggested three major mechanisms resulting in decreased concentration of hemoglobin in red blood cells. So it is decreased on effective red blood cell production. So it's increased red cell destruction and blood loss. Among anemias caused by the decreased red blood cells production. So you will remember that red blood cells are formed in the bone marrow, but many other factors affecting their development and content in the blood. So among these clinical entities caused by decreased erythrocyte production is Diamond-Blackfan anemia, which is mentioned later on, transient erythroblastopenia of childhood, aplastic crisis by the viral infection caused pyrovirus B19, and anemia of chronic disease in renal failure, chronic inflammatory bowel disease, or actually any inflammatory chronic disease. By the way, I should stress that neutrophils contain a lot of proteins containing iron, and so affinity of iron in these proteins is much greater than the erythrocytes. So in chronic inflammation, any chronic inflammation, so neutrophils will draw iron from erythrocyte, making them uh, pale with reduced concentration of hemoglobin. So also the cause is hyperthyroidism. Anemia also caused by severe protein malnutrition, because you know the globin part of the hemoglobin is actually a protein, so lack of protein will result in less production of globin part of hemoglobin. So defect in red cell maturation can be nutritional anemia secondary to iron, folate, vitamin B12. You know that all this trace element and vitamins, they play a role on in maturation and actually division of red blood cells, like in sin and microcytic anemia. It can be sideroblastic anemia and pure red cell aplasia. Decreased production of red blood cells is followed by the increased red cell destruction. So these can be extracellular causes like an hemolytic uremic syndrome, cardiac valvular defect resulting in mechanical injury. It can be autoimmune conditions, including autoimmune hemolytic anemia. You know that it can be seen in systemic lupus erythematosus. or another autoimmune connective tissue, inflammatory connective tissue disease. So infections, drug, toxins, you see that the red blood cells are very vulnerable to everything. Can be thermal injury with severe burns. Intracellular causes of destruction can be red cell membrane defects, enzyme defects like glucose 6 pyruvate dehydrogenase deficiency, hemoglobinopathies like in a sickle cell disease, in thalassemias, porphyrias, and paroxysmal nocturnal hemoglobinuria. So anemia can be caused by blood losses. So it can be obvious occult site of blood losses, gastrointestinal tract, intra-abdominal, pulmonary, intracranial. So a particular risk of massive bleeding, internal or external, can be expected in patients with bleeding disorders, coagulopathies. However, the most common form of anemia in infancy and older children also can result from the lack of sufficient iron for synthesis of hemoglobin. Iron is absorbed in the proximal small intestine, so any troubles in that part of the GIT can result in anemia. So absorption of dietary iron is about 10%, and a diet containing up to 10 milligram of iron daily is necessary for optimal nutrition. So you see that risk ages, as it already mentioned, is infancy and adolescence. It all due because to the growth spurt during these periods. However, the most common form of anemia in infancy and older children also can result from the lack of sufficient iron for synthesis of hemoglobin. Iron is absorbed in the proximal small intestine, so any troubles in that part of the GIT can result in anemia. So absorption of dietary iron is about 10%, and a diet containing up to 10 milligram of iron daily is necessary for optimal nutrition. So you see that risk ages, as it already mentioned, is infancy and adolescence. It all due because to the growth spurt during these periods. Now, what are the common clinical manifestations of iron deficiency anemia? So it's pallor of the skin, blue scleras, pagophagia, the desire to ingest unusual things like ice, dirt. So when hemoglobin level falls down less than 50 grams per liter, irritability and anorexia are prominent. So please memorize that anemia can produce anorexia. The vicious circle closes. Tachycardia and cardiac dilation occur in severe anemia. So again, decreased appetite. The spleen is larger than normal to palpation in 10 to 15% of patients due to fragility of erythrocytes that they destroyed in the spleen and making it larger than normal. These changes resolve slowly with adequate iron replacement therapy. So, with iron therapy, improvement in behavior frequently occurs before significant hematological improvement. Iron deficiency may have an effect on neurologic and intellectual functions. As it has been already stressed that iron deficiency causes rigidity of red blood cells and may be associated not only enlargement of spleen but also stroke in young children. Administration of iron may decrease the frequency of breath-holding spells, suggesting a role for iron deficiency or anemia. Laboratory findings. So normally, serum iron level decreases anemia, and iron binding capacity of the serum increases, and the percent of saturation falls below normal. Red blood cells become smaller than normal, and the hemoglobin content decreases. The morphological characteristics of erythrocytes are best quantified by determination of mean corpuscular hemoglobin and mean corpuscular volume. With increasing deficiency, red blood cells become deformed and misshapen, and present characteristic microcytosis, hypochromia, poikilocytosis, and increased red blood cell distribution with the reticulocyte percentage may be normal or moderately elevated, but absolute reticulocyte count indicate insufficient response to anemia. White blood cells remain normal. Thrombocytosis, sometimes of a striking degree, may occur. In a few cases, thrombocytopenia is seen. Oral administration of simple ferrous salts, including sulfate, gluconate, fumarate, provides inexpensive and very good therapy. The therapeutic dose should be calculated in terms of elementary iron by weight. A total dose of 5 to 6 mg per kg of elemental iron in three divided doses taken after meals provides an optimal amount of the element for the stimulation of bone marrow. If you give adequate dose of iron, what you can expect for the first day. So it's subjective improvement, decreased irritability, improved appetite. During the second day, initial bone marrow response, and you will see erythroid hyperplasia if you make a needle biopsy of the bone marrow. And within the 3 days, you will see a reticulocytosis peaking at the day 5 through 7. So for the first months, there will be increasing hemoglobin level, and within 1 through 3 months, repletion of stores of iron. So as contrary to microcytic anemia, megaloblastic anemia caused by the deficiency of folic acid, vitamin B12, or combination thereof. So both substances are cofactors required in the synthesis of DNA. So ineffective erythropoiesis result from arrest in the development or premature death of cells in the bone marrow. So, folate deficiency anemia. Folates are abundant in many foods, including green vegetable fruits, or animal organs, liver, kidney, and so on, meat. The normal adult daily requirement is about 100 microgram daily. Human and cow's milk provide an adequate amount of folic acid. However, goat's milk is clearly deficient, so folic acid supplementation must be given when it is a main food. Causes of folate deficiency anemia can be related to options. Dietary deficiency of folic acid is not usual in developed countries. However, folic deficiencies may develop in infants or on boiled meal or goat milk. Boiled because temperature destroys the folic acid. And in children who have severe anorexia. The second way getting folate deficiencies, impaired absorption of folate in malabsorptive disorders like Crohn's disease, celiac disease that affect the small bowel. Patients usually have a history of weight loss, poor weight gain, irritability, lethargy, and abnormal stools. Folate, folate deficiency can be caused by increased demand for folate, what's seen in condition characterized by increased cell turnover, pregnancy, chronic hemolysis, malignancy. Relative folate deficiency may follow if the diet doesn't provide adequate folate to meet these needs. The next option is abnormal folate metabolism. So some anticonvulsant drugs interfere with folate metabolism, such as phenobarbital. Clinical manifestations. The peak incidence of folate deficiency anemia occurs between 4 and 7 months of life, somewhat earlier than iron deficiency anemia takes place. Besides having the usual clinical features of anemia, affected infants with folate deficiency looks irritable, fail to gain weight adequately, and have chronic diarrhea. Hemorrhages due to thrombocytopenia occur in advanced cases. Folic acid deficiency may accompany kwashiorkor, marasmus, and sprue. By nature, the anemia is macrocytic, mean corpuscular volume is more than 100 femtoliters. The reticulocyte count is low. Nucleated red blood cells demonstrating megaloblastic morphology are often seen in the blood. Neutropenia, thrombocytopenia may be present also. The neutrophils also lack some with hypersegmented nuclei. More than 5% of neutrophils have 5 or more nuclear segments. So, in normal body, folic acid levels are at 5 to 20 nanograms per milliliter, and deficiency is accompanied by levels less than 3 nanograms per milliliter. The bone marrow looks hypercellular because of erythroid hyperplasia. Megaloblastic changes are prominent, although some normal red blood cells precursors may also be found. Treatment. Folic acid may be administered orally or parenterally in a dose of 1 through 5 mg per day. Because of hematological response can be expected within the first 3 days, transfusions are indicated only when the anemia is severe or the child is very ill. Folic acid therapy should be continued at least 1 month. Vitamin B12 or cyanocobalamin deficiency results almost in the same symptoms like in the folate deficiency anemia. And also, vitamin B12 is derived from cobalamin in food, mainly animal sources, secondary to production by microorganisms. By the way, one study says that depletion of microorganisms in the body can result in vitamin B12 deficiency if there is no so much sources for that. And vitamin B12 result from inadequate intake, surgery, involvement, stomach and terminal ileum, lack of secretion of internal factor by the stomach. What is internal factor? It's a specific protein that covers vitamin B12 and play a role as a carrier through the acidic medium through to the duodenum and to the small intestine where it is after that absorbed. Absence of this internal factor, Castle factor, if it is absent, vitamin B12 is easily destroyed by chloric acid, is not available to the body. So, and you see the last point here, item, that vitamin B12 is present in many foods. Dietary deficiency, therefore, is rare. Sideroblastic anemia. It is anemia in which iron is not utilized in the right way by the erythroblasts. So, sider in the Greek means iron. So, so normally iron enters the erythroblasts easily and freely. Because of a metabolic block, it cannot be incorporated into hemoglobin. Instead, it accumulates in the mitochondria surrounding the nucleus, giving a cell of characteristic appearance like a ring. They call the ring sideroblast when studied for iron content. So again, in sideroblastic anemia, ring sideroblasts are seen in the bone marrow. Ring sideroblasts are erythroid precursors whose mitochondria are loaded with non-heme iron. Main causes of sideroblastic anemia include pyridoxine or vitamin B6 deficiency, pyridoxine dependency, and lead poisoning. Making the diagnosis. All sideroblastic anemias are associated with hypochromic microcytic indices. Stippled, so dotted red blood cells may be found on the peripheral smear. The bone marrow shows micronormoblastic hyperplasia. Ringed sideroblasts are increased iron stones. They are very evident when the cells are stained with Prussian blue. Here's what vitamin B6 is involved. So a trial of pyridoxine in a dose of 50 to 300 mg a day should be instituted for several weeks. If not responsive to pyridoxine, or related to a toxin that can be eliminated, the patient may require support with red blood cells transfusions. Another rare condition is called congenital hypoplastic anemia or Diamond-Blackfan syndrome. It's a rare condition. So children becomes symptomatic in early infancy, frequently with paleness of skin in neonatal period, but it may be first noted after in childhood. Etiology. Dominant or recessive pattern of inheritance are indicated by familial occurrence in about 15% of patients. In about one quarter of patients, there are mutations in gene for ribosomal protein S19 mapped to chromosome 19q13. Some affected infants appear pale in the first days after the birth. Rarely, hydrophytalis occurs. Profound anemia usually becomes evident by the second and the sixth months of life, occasionally somewhat later. The liver and spleen are not enlarged initially. About one-third of affected children have craniofacial deformities or defects of the upper extremities, including triphalangeal thumbs. The abnormals are diverse, with no specific pattern emerging in the majority of those affected. So in laboratory findings, the red blood cells are usually microcytic with elevated levels of folic acid and vitamin B12. Assays of red blood cells reveal a pattern characteristic to a young red blood cell population, including elevated fetal hemoglobin concentration. Adenosine desaminase activity is increased in red blood cells of patients with this disorder. Thrombocytosis or thrombocytopenia and occasionally neutropenia can also be present initially. Reticulocytosis is diminished even when anemia is severe. Serum iron levels are elevated. Prognosis. Median survival is more than 40 years of age. The prognosis is the best in those who respond to corticosteroid therapy. About half of the patients are long-term responders. In others, survival depends on transfusions. Some children in each group may eventually have a spontaneous remission. It's about 14%. Prednisone in 3 or 4 divided doses totaling and 2 mg per kg a day is used as initial trial. Erythrocyte precursors appear in bone marrow 1-3 weeks after therapy is begun, and when normal blastosis and brick peripheral reticulocytosis occur. Hemoglobin may reach normal levels in 4 to 6 weeks. The dose of corticosteroid may be then reduced gradually by tapering divided doses and then by eliminating all except a single lowest effective daily dose. Colleagues, please review a Marshall protocol for tapering corticosteroid. In patients who do not respond to corticosteroid therapy, life-sustaining transfusion at intervals of 4 to 8 weeks should be done. So other therapies including androgen, cyclosporine, high-dose intravenous immunoglobulin, erythropoietin, and so on and so on, do not show any convincing effects, but they also possess a high incidence of side effects. High-dose methylprednisolone, so for in a dose of 30 to 100 mg per kg a day, tapered out of 3 days, has been beneficial in some patients like a shock therapy. Splenectomy may decrease the need for transfusion if hypersplenism or isoimmunization has developed. Bone marrow transplantation has a role in children who do not respond to corticosteroids. Now we switch from the red blood cells to white blood cells and discuss lymphoproliferative pathology. And first we start discussing Hodgkin's disease, accounting for around 4% of all childhood cancer. It occurs in older children and teenagers with slight female predominance. Clinical features of the disease include localized adenopathy, especially in the cervical region, and it is the most common presenting symptom. Systemic symptoms occur in one-third of children. It's temperature exceeding 38, drenching night sweats, weight loss in excess of 10% of the body for the past 6 months. So, four stages of the disease. First one is lymphocyte predominance with many lymphocytes and a few Reed-Sternberg cells. The second stage is mixed cellularity, in which there are more Reed-Sternberg cells mixed with a heterogeneous population of reactive cells. The third one is lymphocyte depletion, with many Reed-Sternberg cells and a few reactive cells. And finally, nodular sclerosis, in which dense fibrotic bands separate islands of reactive cells from Reed-Sternberg cells, variantly called lacunar cells. This is a look of Reed-Sternberg cells and the microscope magnification to let you see normal lymphocyte. And the Reed-Sternberg cells are, you see, as a 5 to 6 times more than the normal lymphocytes. It looks like microphages swallowed free other cells. So for clinical stages, we have four stages definitions. And additionally, any stage are given, subdivided by um, A or B subgroups depending on absence or presence of systemic symptoms. Stage 1. It is when disease is confined to one group of nodes. Stage 2. Disease is present in more than one group of nodes, but it's limited to one side of the diaphragm. Approximately 60% of children have localized stage 1 or stage 2 disease. The third stage involves nodes on both sides of the diaphragm, with the spleen considered being a node. And the final stage 4, there is a hematogenous spread to the liver, bone marrow, lungs, or other non-nodal sites. So this is the figure symbolizing the set about with staging 1, 3, 1, 2, 3 through 4. The picture 1, stage 1, you see the nodes only on the neck. Stage 2, two regions are affected: parasternal and supraclavicular nodes involved but still on the same side of diaphragm. Stage 2, you see that nodes are on both sides of diaphragm, and on the final stage 4, there is spread all over the body. Overall prognosis of the disease is almost excellent and varies from greater than 90% of cure at stage 1 disease to approximately 60 to 70% of cures at the stage 4. Radiotherapy applied to involved nodes plus the next node group to which spread could occur is sometimes used for localized disease. For patients treated with radiotherapy alone, chemotherapy can sometimes be used to successful salvage therapy for relapse. Combination therapy is indicated for all stage 4 and almost stage 3 patients, as well as for patients who have localized but bulky disease such as a large mediastinal mass. Chemotherapy often is given in conjunction with radiotherapy. However, the efficacy and aggressive therapy has late effects, So it's secondary malignancies and like leukemia, non-Hodgkin's lymphoma, thyroid gland dysfunction, and growth disturbances after irradiation, and sterility in later adulthood life. So, non-Hodgkin's lymphomas, they are more rare. It is a heterogeneous group of diseases characterized by neoplastic proliferation of immature lymphoid cells, which, unlike the malignant lymphoid cell in acute lymphoblastic anemia, they accumulate primarily outside the bone marrow. Non-Hodgkin's lymphomas represent approximately 6% of all childhood cancers. They occur predominantly in older children and teenagers and have a strong predilection for males. Childhood non-Hodgkin's lymphomas differ from adult cases that they are a predominantly extranodular in presentation, as likely to be T-cell lymphoma as B-cell lymphomas, highly aggressive, rarely of nodular histology. A subtype of non-Hodgkin's lymphomas, Burkitt's lymphoma, occurs in an endemic form in Africa with a presentation as a mass of the jaw and abdomen. Induction of the B-cell lymphoma in Africa has been linked to a prior Epstein-Barr virus infection occurring in young children who has been immunosuppressed by malaria or another infection such as HIV infection. Morphology. Almost all cases are diffuse lymphomas and are classified as very aggressive. The following types occur. In lymphoblastic non-Hodgkin's lymphoma, the cells resemble L1 and L2 seen in the usual cases of childhood acute lymphoblastic leukemia. In non-lymphoblastic non-Hodgkin's lymphoma, the cells resemble transformed cells of the germinal center, and it may be small, non-cleaved or Burkitt's type cells resembling L3 and acute lymphoblastic leukemia. It can be large transformed lymphoid cells, which, because of their size, have erroneously been called histiocytes. Immunology. T-cell origin is demonstrated in almost half of the cases. The cells generally have a lymphoblastic morphology and contain TDT. B-cell origin is demonstrated in most other cases. The cells are non-lymphoblastic and lack TDT activity. Non-T non-B cells origin is uncommon. True histiocytic and non-lymphoid origin is also rare. All childhood non-Hodgkin's lymphomas are rapidly growing as contrary to Hodgkin's lymphoma, and thus symptom duration is very short. Anterior mediastinal masses, sometimes associated with pleural effusion, are the most common presentation of T-cell on lymphoblastic lymphomas. They can produce respiratory distress, superior vena cava syndrome. Abdominal masses are the most common presentation of B-cell or non-lymphoblastic lymphomas. These lymphomas arise from the either abdominal lymphatic nodes or from intestinal Peyer's patches. They can cause abdominal enlargement from rapidly growing tumor, which sometimes produce pain, ascites, and urinary tract obstruction. Intestinal obstruction by stirring the lead point for the intussusception. Jaw masses are common presentation for endemic Burkitt lymphoma. Peripheral lymph node enlargement can be seen with any type of childhood non-Hodgkin's lymphoma. Less common presentation are obstructing nasopharyngeal tumor, bone tumor, skin tumor. Staging of the disease is used to describe how is the severe the case, and depends on how much of the body is taken by the disease. So And various systems are employed for classifying different types of non-Hodgkin's lymphoma, and they all distinguish local disease of limited bulk, often confined to one side of the diaphragm and carrying a good prognosis, extensive disease with a mediastinum or abdomen, and hematogenous dissemination, especially to the bone marrow and meninges. Therapy. First of all, it should be extensive surgical debulking, removal of at least 90% of tumor. It improves survival for individuals who have abdominal lymphomas. Next, systemic chemotherapy is needed in all cases to shrink the local tumor and to prevent dissemination to the bone marrow and to a leukemic phase. The intensity and duration of therapy depend on the type of lymphoma and the stage of the disease. Radiotherapy is indicated in treatment sites where there is life-threatening obstruction and doesn't respond to chemotherapy. Bulk tumor for which chemotherapy alone is judged inadequate. With appropriate management of the metabolic consequences of rapid cell turnover as well as institution of therapy, a favorable outcome is often achieved. Without therapy, rapid and widespread dissemination occurs. Prognosis. T-cell lymphoma spread to the bone marrow and meninges and all closely resemble T-cell acute leukemia. B-cell lymphomas of the Burkitt's type spread to bone marrow and meninges and closely resemble B-cell or L3 acute lymphoblastic leukemia. Finally, we consider troubles with other lymphoproliferative disorders such as leukemias can be acute, chronic, and congenital. Leukemia refers to the malignant proliferation of immature blastic cells. When the proliferation involves predominantly more mature cell size, the leukemia is classified as being chronic. Acute lymphoblastic or lymphocytic leukemia accounts for approximately 80% of all acute leukemia cases in children. Acute myeloid not lymphoblastic leukemia accounts for the most of the remainder. Congenital or neonatal leukemias are those who are diagnosed during the first 4 weeks after birth. Classification. The further leukemias can be classified according to their morphological characteristics, according to Romanovsky stained bone marrow smears, cytochemical staining properties, immunologic markers, and genetic features. The International French American British classification system yielded 3 designations for lymphoblast: L1, 2, and 3. According to FAB criteria, myeloid leukemia can be subdivided into 8 major subtypes from M0 through M7. For further, immunological markers can distinguish 5 categories of acute leukemia. T cell, B cell, transitional pre-B cell, early pre-B cell. Children at risk of having acute lymphoblastic leukemia include children with Down syndrome, Fanconi's anemia, Bloom syndrome, ataxia, telangiectasia with various immunodeficiency disorders. Because the bone marrow is replaced with leukemic blast, patients present with signs of bone marrow failure, including anemia, thrombocytopenia, and neutropenia. Because the bone marrow is replaced with leukemic blasts, patient present with anemia, thrombocytopenia, neutropenia. Clinically, the manifestation include fatigue, paleness of skin, petechia, bleeding, and fever. In addition, leukemic spread may seen as a lymphadenopathy and hepatosplenomegaly. Other signs and symptoms of leukemia include weight loss, bone pain, and dyspnea. Differential diagnosis of acute lymphoblastic leukemia include acute myelocytic, acute anemia, neuroblastoma, parvovirus B19 infection. You remember this infection in anemias, rhabdomyosarcoma, thrombocytopenia, aplastic anemia, mononucleosis infections, idiopathic thrombocytopenic purpura. Laboratory studies in acute lymphoblastic anemia, leukemia, sorry, it is CBC, hemoglobin and platelet count may be low. You order coagulation studies, prothrombin time, activated partial, prothromblastin time, fibrinogen, D-dimers to assess the presence of disseminated intravascular coagulation. Immunophenotyping. A complete morphologic, immunologic, and genetic examination of the bone marrow is necessary to establish a diagnosis of all. The diagnosis of B-cell leukemia, which account for only 3% of acute leukemia cases, depends on the detection of surface immunoglobulin on the leukemic blasts. T-cells leukemia is identified by the expression of T-cell-associated surface antigen, of which cytoplasmic CD3 is specific. T-cell leukemia cases can be classified as early, mid, and late thermocytes. Cytogenic and molecular diagnosis. In more than 90% of all cases, specific genetic alteration can be found in the leukemic blasts. Other studies include chest X-rays evaluating for presence of mediastinal masses, testicular ultrasound to obtain testicular ultrasound if tests are enlarged on physical examination, renal ultrasound. Some clinicians prefer to evaluate for leukemic kidney involvement to assess the risk of tumor lysis syndrome, and obtain echocardiography prior to the administration of anthracyclines, a sort of chemotherapy drugs that affect ECG markedly. Treatment. The choice of treatment is based on a clinical risk. Three predictive factors are: first, age; second, initial leukocyte count; and third, speed of response to treatment. Different study groups use various factors to define risk, but age between 1 through 10 and leukocyte count less than 50,000 per microliter are widely used to define average or normal risk. Children who are older than 10 age or have a leukocyte count more than 50,000 per microliter are considered to be at high risk, and depending to which group the patient belongs to, the specific therapy protocol is applicable. Generally speaking, initial therapy is designed to eradicate the leukemic cells. It's remission induction. It's called remission induction. During this phase, therapy usually is given for 4 weeks and consists of vincristine weekly, a corticosteroid such as dexamethasone or prednisone, or either repeated doses of native L-asparginase or a single dose of long-acting pegylated asparaginase preparation. Intrathecal cytarabine and methotrexate or both also can be given. Patients at higher risk also receive daunomycin at weekly intervals. With this approach, 98% of patients are in remission as defined by less than 5% of blood in the bone marrow and a return on neutrophil and platelet count to near normal levels after 4 to 5 weeks of treatment. Intrathecal chemotherapy is usually given at the start of treatment and once more during induction. This is almost all we are trying to deliver you the main ideas of the blood disease not only in teenager but also in the small children, as also important in pediatrics. So of course we can cover within this short lecture all aspects of the hematology. It is huge amount of information that can be easily located on the internet. So thank you for your attention. If you have some question on the topic covered or additional questions, material so about the coagulopathy which is not covered here, you can contact me personally or call to me and we will discuss it more details. Thank you very much again and good luck.